Hello and happy Monday. This is Dr. Duke with the Pregnancy and Lactation Considerations lecture. All right, just to get us started off with an overview on what is more of a review, relatively simple, short lecture today, just kind of going over some high points and some important knowledge information in regards to pregnancy. Please refer to your discussion post to see maybe some in-depth things that your peers have shared, articles, interesting facts, etc. All right, so it is estimated that psychiatric illness affects 500,000 pregnant women per year, with approximately 1/3 of women being exposed to some type of psychotropic medication at some point during her pregnancy. When maternal psychiatric illnesses go unrecognized or inadequate treatment occurs, this then results into fewer prenatal care visits, inadequate nutrition. Obviously, there's more potential exposure to additional medications, drugs, substance use, alcohol, tobacco, maybe more resort into looking into herbal remedies, cannabis, and even opioid use. Depression, according to the DSM-5, between 3 to 6% of women will experience the onset of a depressive episode during pregnancy or in the weeks or months following delivery. It is also estimated that about 50% of all major depressive disorder episodes actually begin prior to delivery or postpartum. For this reason, so the DSM-5 essentially has now, for this reason, collects or considers everything collectively as peripartum. So you'll see in the DSM-5 for the diagnostic criteria as peripartum type as a criterion. So you may have major depressive disorder, recurrent, or major depressive disorder single episode, peripartum onset. Okay, so it's got a modifier as a peripartum onset with the DSM-5 criteria. You can begin to go in there and specify specifically to your patient, but peripartum is kind of encompassing during pregnancy, after pregnancy, it's kind of encompassing the whole thing. Multiple factors have been found to contribute to women's risk of perinatal depression. A prior history of depression, anxiety, obviously if they've had work stress, maybe they don't have very good social support, this wasn't a planned pregnancy, there's some intimate partner violence, low socioeconomic status, there's more financial stress and concerns, maybe there's a lack of education, smoking, having a lack of partner kind of goes with lack of social support even. There may be interpersonal even violence and poor personal relationships even possible. All can put you at risk for having perinatal depression. I mean, think about, so, and this a lot of times, especially in teen pregnancy, comes up more and more because of the lack of support or care or knowledge, education, maturity to be able to take care of also, not to say everyone, but it is a large percentage with teen pregnancies and young adult pregnancies as well. And there's actually some interesting statistics and research too when it comes to abuse and things like that. Sometimes the younger parents, because they're just unable to understand what is normal and abnormal, and baby crying and consoling, and get very upset and frustrated, no support, and unfortunately a lot of times there's neglect or abuse. It happens at those points as well. Pregnancy itself can actually also be a risk factor for depression, and it actually can trigger having a recurrent depressive episode in vulnerable women. So if there has been any depression before, maybe through adolescence, and maybe things have been a little bit better, but now we're in our early 20s and there's no help, mid-20s, even early 30s, and no social support, no plan. Maybe it's, the parent, the father doesn't want to be involved with the baby. This can lead to more depression, or recurrence of the episode. So many women experience some affective symptoms during the postpartum period, usually 4 to 6 weeks following delivery. Most women report symptoms consistent with the baby blues. You guys may have been or familiar or heard of this. So baby blues is a transient mood disturbance characterized by mood lability, sadness, dysphoria, subjective confusion, and even tearfulness. Almost crying and not sure why. People say I'm very emotional, afraid to lose my baby. Feel very emotional when holding the child, looking at pictures and cry, and unsure. A lot of times these feelings, they can be natural, they can last several days, and usually it's just because of hormone changes, maybe the stress of childbirth itself, and even just the awareness of now you thought you had responsibility in yourself, and now you are responsible for this life. Taking on this job of motherhood can be a huge taking, that even when you think you've planned, until the baby gets here, sometimes it really doesn't hit someone for reality until holding that baby in your arms. No professional treatment is usually required, okay? Just education, support for the new mother during baby blues. Now, however, if it continues to last and it lasts longer than the 2 weeks, that is when an evaluation usually is indicated for postpartum depression, okay? This is when we're going to look into see if there's more here than just baby blues. So in peripartum depression, the symptoms are depressed mood, excessive anxiety, insomnia, not just because baby waking and breastfeeding and everything else, but really inability to sleep, maybe laying there and worrying and thinking about the baby's health all the time. A change in weight, not necessarily just because, again, delivery, so we have to really be mindful of that. That's a difficult symptom. I feel it's listed in your SODIC because mother is losing weight, but maybe there's actually a gaining weight where the mother should be losing after delivery. Things to look out for if mother's stress eating. Onset is usually generally within the first 12 weeks of delivery, or within those 12 weeks after delivery, okay? No evidence of baby blues necessarily will lead to a subsequent episode of depression, but there is evidence that an episode of postpartum depression increases your risk for major depression. And that is what I've seen in practice myself is, and I've had mother who will, the mother will have the first pregnancy, no problem, have the second child, and maybe there's an onset of depression, and I'll tell you, ever since my second child, you have a few women who say, ever since my first child, I've dealt with depression. Sometimes it's even the first pregnancy and then nothing the second pregnancy. It's very, very interesting to me how this works. And there's women I've even heard on the complete opposite end of the spectrum that during their pregnancy right after was when they felt the best. They actually for once did not have depression. And so obviously there is something there with hormonal fluctuations and levels there, and as to what actually causes this onset. Postpartum psychosis. Now this gets a little bit more of an emergency, okay? Something more that we need to be very alert, make sure we use our really strong assessment skills for safety of the mother and the baby, okay? So now this syndrome is usually characterized by depression, delusions, and even thoughts of harming self or the infant. Usually the incidence is 1 to 2 per every 1,000 births. Typically about 50 to 60% of affected women have just had their first child, and about 50% of those cases actually involve deliveries that are non-psychiatric perinatal complications. About 50% of those mothers do have a family history of mood disorder, but the data and data actually indicates, and I've heard this for a really long time, that if you've had an episode of postpartum psychosis, it usually means that that episode is actually an episode of a mood disorder, most commonly usually with bipolar. And that's what I've heard, and even in my own experience working with a female who did have postpartum psychosis, and bless her heart, was actually had to be hospitalized 3 months after her daughter was born to get her stabilized, was continued on those medications before she come out. She was having thoughts of hurting her child. It was the devil child. It wasn't her. What are you trying to do with her? Get that thing away from me. Really sad story. Really worried, freaked out the in-laws. When she got stabilized, got on her medications, actually became a very good mother, more involved with that child's life than the father actually ever was. And she continued to be treatment and to keep her treatment, because that's the one thing that she remembered is that, hey, I didn't get to see my baby for 3 months. I'm not going to do that again. So she was very, very compliant with her medications and really made a huge difference on taking those medications. She was 18 at the time, which with bipolar disorder, usually the onset of a break, if you guys remember, is usually around that anywhere from the 18 to 20 years old, with 19 being the most common age of a break. So she was right there where she may have had a break anyways, and maybe the hormonal fluctuations, stress of childbirth, etc., on taking motherhood brought it on a little bit sooner for her. All right, so more about postpartum psychosis is, usually symptoms begin within a few days of delivery. And it was interesting that your SODIC said this, because in research that I've read and I've always learned is usually within the first 72 hours. And you're going to know pretty good at what's good about a vaginal delivery, first 48 and C-section 72 hours, depending on the rules of your hospital. But here in Alabama, that's usually the standard to keep the mother And so at that point, most of the time, you're going to see if something's not quite right, and they're not going to have that attachment, get the baby away from me, leave them in the nursery, something's up, okay? More tearful episodes than normal. But your side doctor actually said that the mean time of onset is usually in the first 2 or 3 weeks. So, I guess if it's a section, it's good. You're coming back in 2 weeks for a checkup, but if it's a vaginal, you're not always coming back. So you really need to make sure that we're educating. That might be something for you guys who have an interest in postpartum care or with babies and peripartum for midwives, to making sure that you do a check on that mother, and especially if there's any family history of bipolar disorder or individual history of bipolar disorder, that you're keeping a check with that mother. But as your SODIC says, it's usually, or almost always, within those first 8 weeks, with the mean time of within the first 2 to 3. Okay, that's the meat. That's the really important time right there, is when something can go wrong. Characteristically, the patient begins to complain of fatigue, insomnia, restlessness, may even have episodes of tearfulness, emotional lability. It later turns to suspiciousness, confusion, incoherence, irrational statements, obsessive concerns about the baby's health and welfare may be present. Maybe delusional material the baby's dead or defective. May deny the birth, express thoughts of being unmarried, virginal, persecuted, influenced, or even perverse. Hallucinations with similar content also may be telling, this is where the emergency, may be telling the patient to kill the baby or herself, okay? Please, please, please make sure that you are assessing for safety, using these objective skills on what is that attachment with that baby. Psychotropic medications in pregnancy. And so this is one of those that, look at the discussion in the group, see what they also share for considerations. This is one of those things that is still always a debate. At the end of the day, every patient, as I always say, varies so much, and it really, really does. You have to take the whole picture into play. Is this worth the risk versus the benefit? Okay, does this mother want to take a chance? Is there very extensive, severe mental illness history coming into play? Is this just been a very mild? What is going on with the patient, whether or not we're actually going to treat? Okay, because we don't. So there's no definitive answers that exist right now if they're safe. Okay, a lot of these clinical trials are done on animals, so we don't have a lot of data to show that they're safe in pregnancy, okay, or even with lactation and breastfeeding. What we see with the rat studies, again, not a lot with human. And patients do have worsening psychiatric illness during pregnancy. Outpatient psychotherapy, hospitalization, milieu can even be used instead of medication, so just maybe counseling during that time. If they have to be hospitalized for more closer observation throughout the certain stages of the pregnancy, having a very supportive milieu may be good. Like I mentioned, risk and benefits, sitting down with them, letting them know the risk and benefits. If you're going to do medication with a pregnant woman, you have got to get them to sign informed consent and that they are agreeing to treat despite these known possible things that could happen, or make sure that you are documenting this visit, okay? And if the patient, prescriber, OB, they all continue to decide to do the medications, you also need to take into consideration the dosage, okay? And it may need to be calibrated due to each semester changes, each trimester of changes, first trimester, second trimester, third. First is a lot of times where people will really warrant or try not to have any treatment due to the baby being developed. When everything, the brain, our organs, all those vital things are being developed. Unfortunately, a lot of times that's actually when mothers they're realizing they're pregnant, is that 4 or 6 week mark, sometimes not till that 12-week mark, depending on menstrual cycles, that they really realized they were pregnant. But once if we catch it early enough, they try to take a hold, maybe start some things back in second trimester. Again, taking consideration, depending on what medications in that third trimester, the mother from day 1 of pregnancy may continue the medicines the whole time. It just varies. Sometimes you actually may have maybe you've had a cocktail of 5 and you can keep 1 and 2 and we drop 2 or 3. Again, depending on the patient. So despite antidepressants being one of the most studied classes of medications, again, very controversial. You're going to have, I think even in the OB world, you're going to have physicians who are more comfortable, who are absolutely going to yes, it's not going to hurt. Babies are resilient. Go ahead. And then you're going to have some that let's not take the chance. Let's not take the risk. There's too many things that can happen. And it's a lot of times it's because have been studies that have shown there have been cardiac malformations, preterm delivery, persistent pulmonary hypertension, poor neonatal adaptation syndrome. So they've been more restless and irritable, almost withdrawal-like. And most recently, there has been some cases of autism. And so you're going to have those opinions, whether or not which ones. There are still some SSRIs used more than others that may be an option and not necessarily have to go for something that is as strong or not as safe. So again, the most commonly used antidepressants are SSRIs, okay, and the serotonin or SNRIs, like Effexor, has been used in pregnancy. Most antidepressants are FDA pregnancy category C, back when we had those, okay. That would remember, if you remember those categories, C is it's really just, there's just no studies. We don't know how it would work on animals or humans. We're not saying it has tetragen effects. We're not saying that it does. It's just kind of there. You're taking a risk, okay? However, Paxil, paroxetine, is a category D, so we do know that there is some tetragenicity here and some issues caused from the Paxil, so we do want to avoid that with pregnancy. Not to mention, as you guys probably remember, Paxil, pack on the pounds. Probably don't necessarily want to give this to a pregnant woman anyway, unless she's just driving for weight. But with that category D, there has been some known issues from cardiac malformations, okay, with the baby, and so you really want to try to avoid that if all possible. So starting an antidepressant at a low dose, titrating slowly upward, okay, until remission is achieved, is still the approach by the American College of Obstetricians and Gynecologists and the American Psychiatric Association. So it's still like, hey, we're going to start low, go slow, let's titrate up, let's get the symptoms. They actually rather you titrate that medication and do a higher single dose of medication than necessarily adding and having multiple medications for that mother, okay? For women who have been treated with antidepressants in the past, had positive symptom resolution, and it may even be reasonable to start them back on the same medicine. So if they've been on Prozac like a long time ago, or Lexapro, or Zoloft, those are very commonly used SSRIs in pregnancy. That might be a good thing that you actually can add those back and still get symptom reduction. Exposure to SSRIs late in pregnancy, though, has been associated with poor neonatal adaptation, okay? Again, weaning. Do we start to kind of wean off in trimester, keep first, second, kind of cut them maybe in half, wean them off in the third, or do we keep on through? Again, depending on the baby, but, the mother, but has been associated with poor neonatal adaptation. Again, as I mentioned, jitteriness, some respiratory stress, weak cry, poor tone, breathing issues, and even had to be in the NICU. It has been found, though, in 30% of newborns to women who had been taking SSRIs in the third trimester, but usually most often resolve within 2 weeks of age. So it, again, is this really severe depression, history of suicidal thoughts and attempts, or has this been very generally mild and we can actually begin to wean off by third trimester and we hit that 28-week mark and we can start to come off our medications and see how we do, and maybe avoid having the baby having to go through this first 2 weeks of life. There has been some conflicting literature around SSRI use and pulmonary hypertension of the newborn. At the current time, the risk of persistent pulmonary hypertension as a result of exposure to antidepressants in utero is actually inconclusive. So although this is listed and even in your stalls as a potential side effect of an SSRI in pregnancy, it's actually, it's a hit or miss right now. They have not actually had conclusive, for sure, confirmed evidence of that. So venlafaxine or Effexor has been used in pregnancy, although on a much smaller scale, okay? So a whole lot less often compared to SSRIs. There is limited data that suggests this medication has not resulted in a significant increase in the rate of congenital malformations. Again, think about it, serotonin and norepinephrine is hitting you an additional chemical, so we may still have more risk there, especially with stimulating in its behavior with norepinephrine. May have some effects cardiac-wise. TCAs are actually widely studied in pregnancy and do not appear to be associated with structural malformations in infants exposed to utero. However, Due to their anticholinergic adverse effects and toxicity of overdose, they're literally reserved for those treatment-resistant depression. And it's very interesting, you're going to see here in a moment too with antipsychotics, the oldies but the goodies, sometimes it's just because they've been around for so long that maybe do we not have perfect clinical trials? No, but the fact that we have use after use after use for so many years because people have been pulling anything to help these people, sometimes you'll see that maybe they're not as bad as what they seem like they could be in pregnancy. Maybe the baby is more resilient than we thought in some cases. So now what if the mother is already on an antidepressant and, having some depression throughout pregnant, or not having depression, but just whether or not to make that decision. Do we stop the medication? Do we continue the medication throughout the pregnancy? Obviously, that decision is very complex. Okay, pregnant women often feel quite uncertain and conflicted when making that decision whether do you want to continue or discontinue. They should be cautioned, though, that the risk of relapse and depression is high. One study found that women who maintained antidepressant medication use throughout the pregnancy had 26% relapse of major depression compared to 68% of those who discontinued. So, 26% who stayed on it compared to you have a 68% chance if you stop your medication you have relapse of depression. It's a whole lot, almost 3 times more likely for you to have a relapse. So it's we want to keep on the medication. Again, depending on what you're on, depending on the dose, depending on the situation. But 60% of women who did discontinue their treatment at the beginning of pregnancy restarted again during pregnancy. And that may be because you tried and you wanted to be safe, and then unfortunately those depression symptoms came back. A reduced dose does not appear to reduce fetal risk, and the risk of relapse is substantial for women on medication if the dose is subtherapeutic. Okay, so just cutting it in half, trying to be safe, and is always not the best thing. All right, you may actually relapse the woman, and then you're having to push the medication back up anyways, and you've actually had some damage with the stress and everything else to the mother, and possibly, we don't know exactly what it does to the fetus in that relapse of depression. So just whether or not we are stopping this or keeping this, okay? Women should be advised to take the prescribed amount of medication to achieve the most remission symptoms. That means not playing around with their medicine, not sure we're either doing this or we're not doing this, okay? So if the mother wants to stop the medication, makes a decision like, okay, let's stop, all right? Maybe this is, I want to stop because I'm pregnant, or I want to stop because I'm getting my 3rd trimester, whatever it be. Okay, I think I've got this, I can handle this, I've had a pregnancy before and I did it, I can go without, right? Some women want to stop taking antidepressants as soon as pregnancy is discovered, all right? And so women want to just continue to reduce their dose of antidepressant because of that, or who may be at particularly high risk for that period of depression. But as we just said, statistics have showed reducing, you still may more likely to have this chance of relapse, okay? I already mentioned before if it was mild, this may be appropriate. If we decide to, you're not going to withdraw from SSRIs, remember, okay? There's not technically a withdrawal. Now, if it's Zoloft, sometimes you have those little brain zappy things, and Paxil, you may not feel so great, all right? For the most part, though, you can generally stop an SSRI, just stop it. However, in a pregnancy, though, we're carrying a baby, not knowing exactly, they do recommend that we cut or taper about 25% every 1 to 2 weeks just to avoid any withdrawal symptoms, okay, or any rebound depression coming back quickly, especially depending on what dose you're on. She should be encouraged to use exercise, light therapy, there are other modalities that may help. Someone has once asked before about St. John's wort. There's actually no clinical studies or research showing that has been effective for women with perinatal depression. Again, and also on that same spectrum, not necessarily any that's possible risk to the baby, but not necessarily that's been successful either. So just kind of hit or miss. If it's to the point where you need something, that might be, again, thinking about the medication. A strategy is tapering off antidepressants in 3rd trimester to try to help reduce the neonatal withdrawal symptoms, is what I talked about. But there is no evidence, again, that tapering or discontinuing antidepressant medication near the term is effective in terms of preventing the transient neonatal complications. So even if we do cut the dose, you've been on 20 Lex for the whole pregnancy, we get to 28 weeks, we cut it in half to 10, there's still actually no evidence that if we taper or discontinue that, say we cut it in half, doesn't necessarily mean we're going to prevent, okay? Even if we go ahead and wing to stop, it's still possible. We don't have absolute evidence for sure that we can prevent it from happening. So bipolar disorder in pregnancy, and we mentioned this just a little bit because we started to get into this in touch points when we talk about postpartum psychosis. But the risk of relapse is not reduced during pregnancy and increases substantially actually after childbirth by a relapse of bipolar disorder, okay? Bipolar disorder in pregnant women has been associated with increased risk of antepartum hemorrhage, prematurity, low birth weight, and intrauterine growth restriction. Women with bipolar are also at high risk for experiencing a mood episode during pregnancy, as well as exasperation during the postpartum period. There is clear linkage between medication discontinuation and relapse. Studies have found that between 80 to 100% of women who stop their mood stabilizer during pregnancy will experience relapse very soon after medication is discontinued. Okay? Bipolar episodes are also associated with increased risk of alcohol use, illicit drug use, tobacco, nutrition, suicide. I mean, all these things, even like if you're not pregnant, I mean, these relapses of bipolar disorder can already lead to that anyway, especially without being treated. But pregnancy is just another thing that's linked onto it that can make it more likely that you're relapsing and you might be resorting to other things. And we're so worried about the medications, but we think about the risk of alcohol, drug use, tobacco, gosh, not taking care of themselves. It can be so much more suicidal. May not even have a mother or baby. You know, there's so many more risks sometimes that come into play. And again, when I say look at the whole picture, what is going to be best for this mother, okay? So pregnant women, as I already said, I keep saying, face that dilemma. Do we continue or not to continue? That is the question, right? So obviously implementing pharmacological options, there's going to be a risk, okay? The risk-benefit decision-making model directs the treatment of structural bipolar disorder during pregnancy and is based on the risk of no treatment versus reproductive toxicity, whether it does come in intrauterine prenatal death, physical malformations, growth impairment, behavioral heterogeneity, and neonatal toxicity with these medications. Mood stabilizers are typically first-line medicines used to treat bipolar. Except for lithium, many of the medications are anticonvulsants, and that's correct. And we already talked about the bipolar, right? Depakote, which is valproate, carbamazepine, Tegretol, lamotrigine, Lamictal, those are all anticonvulsants, okay? Lithium, so it's kind of the one that's not the anticonvulsant, but we know it's a great mood stabilizer, right? Gold standard for normally bipolar disorder. There was a lot of research there for a while, or there was a lot of saying, I guess, per se, that lithium was associated with cardiotoxicity and Epstein's anomaly. However, there are now some cautions in literature that maybe the risks have been overestimated. Maybe it's not something to freak out about as much, and lithium may still be a good option during pregnancy. I remember very, very clearly, actually, when I was doing my hours with a psychiatrist in residency years ago, and he had a mother on lithium who was breastfeeding, and it just stumped me. Like, wow, no, that's past the breast milk. Why are you? But in his eyes was the mother was being controlled, and the mother had wanted to continue, that it was very important to her to breastfeed, and so it was that choice of, look, I'm not going to take this medication if I can't breastfeed my child. So there was risk one, mother not being stable, and then two, his actual belief that the breast milk was still better in the end with the antibodies and the things that the mother gave in the breast milk was better ultimately than formula. And so he thought the little lithium wasn't going to actually hurt the baby. Now, as baby begins to wean off of breast milk, there may be a little bit of withdrawal there for a little bit, but it's usually pretty transient and short-lived. So, but I thought that was very, very interesting. And there is also some irritability that can come with the baby getting the lithium to the breast milk and some sedation, etc. So, things to keep watch for. But I have seen lithium in practice, and it has been used. So, perinatal exposure to valproate or Depakote. Now, here's the no-no, though, okay? Lithium may be a valid option, all right? So, valproate or Depakote associated with 1.1 to 3.8% risk of neural tube defects, craniofacial anomalies, fetal valproate syndrome, varying degrees of cognitive impairment, neonatal risk for hepatotoxicity, coagulopathies, neonatal hypoglycemia, and withdrawal syndrome. Depakote is not an option. It's really not a great idea at all to have a pregnant woman on Depakote, okay? There are other mid-stabilizers you may be able to use besides the Depakote. If they're already on Depakote prior, this is maybe one that we are going to be working on wean, and what can we fill in its place, okay? Carbamazepine or Tegretol has been exposed during pregnancies associated with fetal carbamazepine syndrome, facial dysmorphism, and even fingernail hypoplasia. So there are some fetal risk with that one, not as much pronounced as the Depakote. Lamotrigine, now this is a really interesting thing, and lamotrigine overall is more tolerable a lot of times than some of our other mood stabilizers with bipolar disorder generally. But there's increasing evidence used in pregnancy and bipolar maintenance as a result of it being protective, actually. Its protective effects against bipolar depression, tolerability, and growing reproductive safety profile that's beginning to be more and more used. Remember, the only negative, though, with the lamotrigine is you have to start low and go slow. So it may not be something if you're at risk for a mother rebounding. You may need something else on board to stabilize her, okay, and be starting the Lamictal, absolutely. But you may need something a little stronger, or maybe like an antipsychotic we may have to pull out, and we'll talk about those in just a moment. And here we are, right? So, antipsychotics in pregnancy. The potential risk for abnormal muscle movements, EPS, withdrawal symptoms, newborns. Yes, that's still, if the baby is exposed to antipsychotics during third trimester, that is possible, okay? Atypical antipsychotics, though, have been replaced or have replaced the typical agents, just as we talk about in general bipolar treatment or psychosis. We do see more of atypicals being used. Lurasidone or Latuda is actually the first and only category B antipsychotic currently. And so that means that it's been tested in animals. They actually did a 500 times fold in rats, and still no birth defects with having the Latuda in their system for the pregnant rats. There were no birth defects to the babies. Reproductive safety data still, though, remains extremely limited, okay? And although adequate and well-controlled studies have not been done in one of these antipsychotic drugs, here we go, animal studies, all right, have revealed the evidence of tetragenic or embryo fetotoxic effects in all of them, meaning not the Latuda, okay, but in the other ones, you know, when it comes to maybe that's Haldol, Risperdal, Seroquel, Vilify, Thorazine, Stelazine, etc. There may have been some kind of tetragenic or birth defects caused from these medications. Congenital malformations and perinatal death have been reported with clopramazine. Okay, haloperidol used during pregnancy has been linked to severe limb reduction defects. But I want to stop right there. So I remember sitting at the state hospital and actually working, and we were talking about how Latuda got its category B when it was coming out, and how, wow, like, that's great, there's an option. And my psychiatrist looked at me, and I may have shared the story already through lecture, who looked at me and who said, well, but it's not going to always be as safe, in my eyes, as Haldol. And I just wanted to fall off the chair. Like, Haldol? What? But yes, because it goes back to the whole thing. These typical antipsychotics have been around for years and years and years. So although, yes, do we not have the exact clinical trials and research to test, but we've had women who've been on those medications, who've had successful deliveries with healthy babies, despite these things that we've seen. Yes, like even the next one, chlorpromazines cause the baby to be very drowsy, lethargic, you know, when they're being breastfed, which I mentioned that's even like with lithium. But these typical antipsychotics, you know, the Thorazine, Haldol, Prolix, they've been around for so long that, you know, I don't know, it goes back to that whole risk. There's a risk for any of these medications that you stay on. They are category C. We don't know, okay? But it's an option. Again, depending on the severity of your patient, though, okay? So just take those in consideration. So anxiety in pregnancy, though, obviously first line, we're gonna try SSRIs first, right? Benzos are not our cup of tea. That's not where we want to go. All right. However, sometimes they are. All right. The FDA did categorize benzos either D or X. It's really something we don't want to use. I'm not gonna lie. You're gonna see them. You're gonna see them. You guys probably already seen them through practice. You're gonna see them with pregnant women. And what are you supposed to do? You know, there's, again, a debate whether or not that you stop the benzo immediately but then you have the mother have issues and inside, the neonate have issues as well with withdrawal. Do you slowly wean? Do you just mother on it the whole time because babies get used to it and let them withdraw at the end? Uh, you're going to see many very varying opinions. If the maternal use of benzos, if they continue, okay, so shortly before birth, they're still on it, the baby's going to be born, there is more risk of floppy infant syndrome, hypothermia, lethargic, poor respiratory efforts, and even feeding difficulties, though. So that's where maybe this is the medications. These are the types that maybe we do want to try in third trimester to start trying to wean down, okay? Experts note that benzos do not pose significant increase in the long-term risk, though, and can be safely used if necessary. So what they're saying is that the short-term, the withdrawal, it's there, the risk is there, but they're saying that not long-term down the road is the baby's still going to suffer. Not that they have the trials or proof right now, okay? But if we are going to stop them, as always, taper them. Do not abruptly stop, okay? Just depending on how fast you taper, again, take the mother in consideration, the whole picture. All right, as I mentioned, just a very relatively short lecture. Hope to see you guys jumping into the discussions this week and see what you guys have. If you have practiced midwifery of women's health and you have some good tips and stories, please share with us. I even myself love learning and seeing different stories out there and what people have used and success stories, or have seen on the opposite end of that with the babies born, or were these okay? I mean, were there any safe deliveries? Were these things that you've seen in your practice that you try to avoid? I think it's wonderful to add to the course. So you guys all have an absolute wonderful week, and we'll see you in the next lecture. Thank you guys.